This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Thank you for coming to our Fellows Conference this morning. Today we have two journal articles that are going to be presented. The first will be by Dr. Quentin Loyd, who is one of our third-year fellows on the clinical track. He joined us from the University of Miami, and we're lucky to have him here. He's going to be going into EP next year, which we're very excited about. And then the second will be presented by Sophie Vitter, who is one of our Emory residents that we were lucky to keep here for fellowship. She's also a third year fellow on the clinical track, and will be joining practice after she's done here this year. What we'll do, I think, is we will have Q start with his journal article first, then we'll have some discussion, and then we'll have Sophie go after that. So take it away, Q.
Hey everyone, like Dr. Coley said, I'm Quentin Loyd. I'm one of the third year fellows. I want to thank everyone for joining Journal Club today. Hopefully it's a good talk for you. Today I'm going to be going over a trial that was recently published that's generated a great deal of attention in the HOCM space, the Maple-HCM trial, which essentially compares Aficamten monotherapy to Metoporol monotherapy for symptomatic HOCM. The study pretty much asks a straightforward question. If you strip away all the background meds and make the therapies go one-on-one, which one actually improves symptoms and gradients in exercise capacity in patients? I think this study is particularly relevant for us because it evaluates a targeted mechanism-based therapy, the myosin inhibitors, against what's traditionally been our first-line therapy, beta blockers. And as you'll see in the trial, was essentially designed to provide a clean head-to-head comparison. And of these two strategies and the results, honestly, have important implications for how we deal with our symptom management and functional capacity in our HOCM patients. So today we'll talk through the rationale, the trial design, the results, the safety data, and of course, what all of this means for our HOCM patients. We'll start off by taking a few questions first, a few minutes for questions. And feel free to enter them in the chat. And Dr. Cole, if you could tell me which ones most people are
Yeah.
saying.
Do you want to read the question? Maybe I
Yeah.
can
So in
kind
a patient with suspected HOCM, which of the following combinations most strongly suggests true dynamic LVOT obstruction rather than mid-cavitary obstruction or artifact? A, late peaking Doppler envelope, gradient greater than 50, and SAM without septal contact. Early peaking Doppler envelope, Bispherians waveform, and basal septal hypertrophy. C, late peaking continuous wave Doppler signals with SAM septal contact and posteriorly directed MR. Or D, resting gradient greater than 30 with a normal mitral valve and centralized MR jet.
that we're getting a lot of C's, and I'm chuckling because Dr. Williams kind of led off the answer, so I think none of us want to disagree with the HCM expert.
Right. Yeah. So that's correct, though, of course. So the combination that mostly convincingly tells us that this is true LVOT obstruction is the late peaking Doppler signal with SAM septal contact in the posterior MR jet. That triad is basically the signature of classic HOCM. Late peaking flows mean the obstruction worsens as the systole progresses. And then the SAM septal contact is actually the mechanism of the obstruction, and the posterior MR jet tells you that the mitral valve is actually being dragged into the outflow tract. The other options all miss something important, like SAM without septal contact, early peaking flow, or the MRI centrally directed. These findings can happen in HOCM, but they don't definitively prove LV2 obstruction. So that's why C is really locks in the diagnosis on this one. Good job. So in a symptomatic NEHA 3 patient with HOCM and a resting LVOT gradient of 70 millimeters of mercury, which management decision is least supported by current evidence or guidelines? A, starting a non-vasodilating beta blocker and titrating to maximally tolerated dose. B, considering early referral for septal reduction therapy at an HOCM center. C, starting verapamil in a patient with resting hypotension, systolic blood pressure of 95. Or D, considering a cardiac myosin inhibitor if symptoms persist despite optimized medical therapy.
We got a lot of C's, and I think Ravi this time did not put in his answer. I appreciate because then we can all guess that.
Yeah, exactly. So verapamil is the one option that really doesn't make any sense. It's a negative inotrope and a vasodilator. So starting in someone who's already hypotensive is risky. It can actually worsen the obstruction and drop the blood pressure further and make the patient have even worse symptoms. Actually, the other ones are actually all pretty much guideline supported. So C is really the really most dangerous one in this case. And then the last question. Sorry, which everyday situation is most likely to make a HOCM patient's LVOT gradient shoot up faster than a resident hearing the attending is running early today? A, drinking an iced coffee too quickly. B, taking hot yoga a little too seriously. C, getting dehydrated, standing up fast and saying, I'm fine. Or D, switching from metoporol to cold brew because it gives me more energy.
Lots of B's.
Yep. So the situation that essentially, yep. So for this one, actually, I said C.
Hmm.
For this one. Yeah. So I thought the situation most reliably that makes the LVOT gradient spike fast is when a patient is already preload, their preload is already down, and then they have a sudden quick change in position. When a patient stands up fast and is already volume depleted, I think the LV cavity gets smaller, the sound worsens, and the gradient shoots up almost instantaneously. The other ones, like the iced coffee, the hot yoga, switching to cold brew, they might increase the heart rate a bit, but they don't consistently, I think, trigger that sharp preload related gradient that surge we see with C. So that's why I pick C.
I
That
would accept B or C as a correct
Yes.
answer.
is
Yeah.
B
I
is
actually thought
you're
B too.
also
Yeah, yeah,
getting
the hot yoga, the
dehydrated.
vasodilation. Yeah,
Yeah, with
exactly.
Yeah.
the if you get really volume depleted doing too much hot yoga, that'll do it too.
That's fair. Let's see. All right, so before we jump into the trial, let's talk about learning objectives. First, we'll talk about why the Maple-HCM trial even exists, what clinical gaps it was designed to address, and how the trial was structured, including a design feature and endpoint selections. Second, we'll talk through the key results, which include the primary endpoint which was the change in peak oxygen consumption, the major secondary endpoints related to symptoms, gradients, and biomarkers, and as well as the key safety, efficacy, and safety findings. And then finally, we'll look at what this all means for our HOCM patients in terms of modern management and then future research. So let me set the stage a bit. So hokum is a lot more common than people actually think. I think is what I was reading is as frequent as about 1 in 500 people. In some reports, I saw 1 in 200. We just don't diagnose most of them. And of the people who we do identify with hokum, I think a big chunk of them, like two-thirds, have some sort of obstruction, whether it be at rest or with provocation. And that obstruction is usually what causes patients to have symptoms. And the physiology is pretty straightforward. The basal septum thickens, the mitral valve gets pulled towards the outflow tract, and then suddenly the LVOT space gets narrowed right when the ventricle is trying to eject. So now you've got higher pressures in the LV, not enough forward flow stroke volume, and the patient in turn gets all the symptoms we associate with HOCM: shortness of breath, exercise intolerance, chest discomfort, and that presyncopal feeling that patients always describe. And over time, all that pressure and altered flow just feeds into diastolic dysfunction, which in turn causes a big left atrium, causes more MR, and eventually atrial fibrillation these patients will often develop. Our traditional meds, the beta blockers, the non-DHP calcium channel blockers, disopyramide, they all can help, but they're pretty much like helping indirectly in reality. We're basically trying to calm down the heart and hoping the gradients improve. And sometimes it works, but sometimes you get very little improvement in these patients, and that's because they don't really address the actual problem, which is the sarcomeres being way too contractile. And then if someone is still pretty symptomatic, we start talking about septal reductions and myomectomies and alcohol ablations. And those work really well, I think, in the right hands, but they're big specialized procedures, and not every patient wants to go down that road. So that kind of leaves us with a gap in treatment. And we had not had a drug that actually targets the true mechanism, the hypercontractility itself, in any meaningful, precise way. Everything we've used so far today is essentially like a workaround. So the myosin inhibitors are pretty much the first real attempt to fix the thing that's actually driving the problem. They actually turn down the excessive cross-bridge activity at the sarcomere level. And when you do that, it makes sense that the gradients fall, the feeling improves, the wall stress drops, and patients start to feel better. So naturally, the next step was, okay, if we have something that actually targets the mechanism, can it beat the old meds we've used forever? That's basically the setup for the Maple-HCM trial. And the whole reason this trial was even needed goes back to what actually drives symptoms in HOCM. The heart is essentially hypercontractile, pushing the mitral valve into the LVOT and creating this dynamic obstruction that spikes the intracavitary pressures and dials down the amount of forward flow. So in reality, it's no surprise that people feel terrible when their heart is doing all this at once. And the cold truth, I think, is that our traditional meds haven't been great at fixing the core issue. We're slowing down the rate, reducing calcium channel, and maybe softening contractility a little bit, but we're not actually touching the molecular machinery that's causing the problem. And I mean, sometimes patients feel better, but not as often. And I think that's where the myosin inhibitors come in. Instead of trying to nudge the heart into behaving, these drugs pretty much go straight to the sarcomere itself and actually dial back the excessive actin myosin and bridge formation. Aficamten specifically was designed to do this in a controlled and reversible way, faster on, faster off. So we can actually modulate hypercontractility without the same risk of prolonged EF suppression. And we've been using beta blockers forever, mostly because they were good enough and no one really ever challenged them head on. So I think this trial was built to do exactly that, a clean monotherapy head-to-head comparison. And at the end of the day, the rationale is pretty simple. We finally have a therapy that targets the actual mechanism of obstruction. So the trial asks whether a new approach can outperform the older, more indirect strategies we've all been using for decades. And if so, that could completely reshape, I think, the way that we consider first-line therapy for HOCM. As far as the trial design itself, the investigators pretty much set up a phase 3 randomized double-blind, double-dummy design, which basically means everybody took two pills, one active and one placebo, so nobody actually knew which treatment they were going to be taking. They enrolled the patients with symptomatic HOCM, mostly that had a NEHA class 2 or 3. Everyone had to exhibit a real obstruction, at least a resting gradient of 30 or a gradient of 50 with Valsalva. So this is essentially a very truly obstructed population, not just borderline patients. Before randomization, they underwent a full washout of all negative inotropes. So no beta blockers, no verapamil, no diazepam, or no disopyramide. The whole point was to remove anything that could lower the gradients on its own. So whatever happened during the trial was actually from Aficamten or Metoporol. And then after the washout, about 175 patients were randomized 1-to-1. One group got the Aficamten starting at 5 milligrams with the option to titrate up to 20 milligrams plus placebo metoprolol. The other group got the metoprolol succinate starting at 50 milligrams and titrating up to 200 milligrams plus placebo Aficamten. And even the titration itself wasn't casual. It was actually guided by scheduled echoes that the patients got. Essentially, everyone stayed on the therapy for about 24 weeks. And then the primary endpoint was the change in peak oxygen consumption on CPET, which is actually one of the cleanest ways we have to measure functional capacity. And then the secondary points were all the usual HOCM metrics we care about: NEHA class, KCCQ scores, LVOT gradients at rest and Valsalva. They checked NT, pro-BNP levels, left atrial volume index, and LV mass, etc. So overall, I think Maple-HCM gives a very controlled, essentially apples to apples comparison, Aficamten by itself versus metoprolol by itself without any background medications muddying the waters. And so now we'll take a look at the actual patients that were in the study. So when you look at table 1, you see essentially a very typical HOCM population, not end stage, not wildly atypical, just the kind of patients we essentially see in clinic. The average age was about 58, so right in that middle life range where symptoms start usually to get where patients can't really ignore them. A little over 40% were women, which is actually a nicer balance than we've seen in some of the earlier HOCM trials that skewed heavily male. Symptom-wise, almost everyone was NEHA 2 or 3, so these were definitely patients that were symptomatic, not people with mild or like borderline physiology, but also not so advanced that you'd worry that they couldn't finish like the CPET or might struggle to complete the protocol. And then just classic HOCM patients, symptomatic, limited, but still functional. Their obstruction lined up with what we normally would expect. Resting LVOT gradients were in the mid-40s. With Valsalva, they jumped to like the 70s. That's, I feel like, essentially the textbook obstruction pattern we see, enough to improve, but not so extreme that the baseline data feels skewed. Something worth noting that's not shown here is that in the supplemental, it was that a third of the patients were either newly diagnosed or treatment naive. naive, and I think that's important for the washout period. The washout made everyone start from the same pharmacological baseline, but having that many treatment naive patients usually means their physiology was a bit more untouched, so to speak. And I think that sometimes translate into a clearer treatment effect. So it's good to have that into context. And then structurally, their hearts look like what we see in straightforward hokum. So the left atrial volumes were moderately enlarged, consistent with chronic diastolic dysfunction. LV mass index was elevated, but not in the extreme range you get to see in more advanced and fibrotic disease. And then the ejection fractions were preserved, even on the higher side, which is what we expect in HOCM patients. Overall, the two groups I think were well balanced. There weren't any glaring differences in age, sex, knee-high class gradients, or structural parameters. So I think from a baseline standpoint, the randomization was clean. The population really reflected a broad slice of what the standard HOCM patients we see in clinic, but not like advanced or burnt out patients. And that's helpful because it gives us confidence that the difference we see later on in the study, especially in the peak oxygen consumption and gradients, is actually the treatment effect and not the result of the baseline imbalances between the two groups. So now getting a bit into the results. So now that we understand who the patients were, the next big piece is the primary endpoints, which I mentioned earlier was the change in peak oxygen consumption at 24 weeks. And this is actually a really important choice because in HOCM, symptoms come from a whole mix of things: dynamic obstruction, trouble augmenting stroke volume, chronotropic limitations, diastolic stiffness, and even microvascular ischemia. So using peak oxygen consumption is a measure that essentially integrates all of that. It's a much more honest and physiologic readout than just simply asking someone what your knee high is on a given day. I think what the trial found is that the two groups moved in completely opposite directions. The Aficamten group actually went up in peak oxygen consumption by about 1.1 milliliters per kg per minute, which in this population is actually really meaningful. These patients often have very limited ability to recruit stroke volume or heart rate reserve. So even a 1 point jump is something that can realistically patients can feel. Meanwhile, the metoporol group actually dropped by around 1.2 milliliters per kg per minute, which understandably is exactly what you'd expect from a beta blocker in a HOCM patient trying to exercise. You're essentially blunting their chronotropic response and the physiology already struggling to increase their output under stress. So when you put those changes together, you end up with roughly a 2 to 2.3 milliliter per kg per minute separation between the therapies. And in the CPET terms, that's not subtle. That's the kind of difference that actually shows up in patients' daily lives. So we're talking about the difference between someone being able to walk to the mailbox and getting winded and someone being able to go a few flight of stairs without stopping. And what I like about this result is that it's not just statistically significant, it's actually physiologically coherent. And the peak oxygen consumption in HOCM patient really reflects the whole system behaving or misbehaving under stress, dynamic gradient relief, better forward flow, improving diastolic filling, wall stress gets reduced, and then you have more efficient contractility. And I think Aficamten directly reduces the hypercontractility and unloads the LVOT, which essentially gives patients more stroke volume reserve. Metoporol, though, by design, limits heart rate augmentation. So the decline we see here is actually what the physiology predicts. If you translate the oxygen consumption changes into more clinical intuitive threshold, like let's say more than 1 milliliters per kg per minute improvement, about 45% of the Aficamten patients actually achieve that, compared with only about 15% in the metoprolol group. And that's roughly a 30% absolute difference in the likelihood of feeling better. And then functionally, that works out to a number needed to treat of about 3, which is really impressive for a chronic structural heart condition. Essentially, treating 3 HOCM patients with Aficamten instead of metoprolol gives an additional patient a meaningful, better exercise capacity. So the primary endpoint really gives us a clear, believable story that Aficamten improves integrated physiologic performance in a way that patients can actually feel, and while metoprolol tends to blunt that performance. And the size of the difference, both statistically and clinically, really sets the stage for looking at what happened with symptoms, gradients, and biomarkers in the secondary endpoints, which is what we'll talk about next. So now that we've kind of talked about the primary endpoints, which really showed an impressive separation in peak oxygen consumption, the next question is whether that improvement actually shows up in the things that patients feel and the physiology that we care about. And honestly, this is where the trial is even more convincing, in my opinion, because every second endpoint essentially moves in the same direction. It's one of those rare situations, I think, where all the data points seems to agree with each other. Starting with the knee-high class, which is understandably the things patients complain about the most. Often half the Aficamten patients improved at least by one knee-high class over 24 weeks. In the metoprolol number, that number was only about a quarter. So that's about a 25% absolute difference, basically a number needed to treat of four, meaning if you treat four Holcomb patients with Aficamten instead of metoprolol, one additional person actually feels better on their day-to-day symptoms, and the relative improvement is almost doubled. And that's not a subtle sign. I think that's something that patients actually notice. In terms of like the quality of life, it tells the same story. The KCCQ clinical summary score, the Aficamten patients improved by around 15 to 17%, while the metoprolol group improved by around 9 to 10. So you get a between group difference of about 7 points, which is comfortably above the 5 point threshold where patients actually tell you they feel better. And then the gradients, I think this is where the Aficamten in the trial actually really shows off. So the resting gradient dropped by about 30 to 40 millimeters of mercury with Aficamten, whereas the metoprolol group saw maybe a 5 to 10 millimeter of mercury reduction. And with Valsalva, the difference was even more dramatic. You're looking at about 30 to 40 millimeters of mercury separation between the two therapies, actually. And I think if you use like a practical threshold, like achieving a resting gradient of like 30, Aficamten gets you there about 70% of the time, and then metoprolol maybe about 20 to 25% of the time. And then the biomarkers, it even has the same pattern. The NT-proBNP fell about around 20 to 30% in the Aficamten group, while the metoprolol pretty much hit a curve and was basically flat the whole time. And same thing with the left atrial volume index. You saw about a 3 to 5 milliliter improvement over 6 months with Aficamten. And the LV mass essentially stayed relatively the same, which is what you expect, because we're essentially improving the physiology, but not really dissolving myocardium. So the fact that that stayed the same was essentially expected. So I think when you zoom out, the overall story for this trial becomes clear, in my opinion, that Aficamten improves symptoms, improves the quality of life. I think it drops the gradients dramatically, reduces biomarker stress, and it even nudges the remodeling in the right direction, in my opinion. And importantly, all these signals lined up with the primary endpoint and with each other. So I think that kind of internal consistency is exactly what makes the secondary endpoints in this trial really compelling. So as far as like the strengths in, sorry, one second. All right, so after we look at the primary and secondary endpoints, I think the next question is essentially, is this medication actually safe? And I think the reassuring part of the Maple trial is that the safety profile is really clean, especially when you compare with what we're talking about, a drug that actually reduces contractility. If you look at the overall adverse events, the two groups were basically indistinguishable, 74% on Aficamten, 76% on metoprolol. In other words, about three-quarters of patients reported something, which is understandably what three-quarters of Holcomb patients do before we start thinking about any type of therapy for them. Serious adverse events, I think, were essentially the same, around 8% with Aficamten and like 7% with the metoprolol group. Nothing about those numbers, I think, suggests a new safety issue or a specific cluster of events that stands out. Now, the piece that everyone focuses on is the EF, because anytime you say negative inotrope, we're gonna immediately go to thinking like what's gonna happen to the patient's EF. And yes, Aficamten did lower the EF slightly by about 4 points on average, but the important nuance for that is the EF still stayed roughly in the normal zone. I think there was only one patient that had a dip below 50%, and even that didn't fall into territory that would make you panic really. And just to round out the safety picture, the EF didn't really happen in like a vacuum. I think the trial built in echo-guided titration from the start, checking the EF at the baseline, checking it during dose adjustments, and keep nudging the dose as long as it stayed safe for the patient. So I think the small dip we see in EF with Aficamten is really just the expected on-target effect of the myosin inhibitor and not really a uncontrolled slide into dysfunction. And outside of the EF, the safety profile stays relatively calm, I think. There weren't any meaningful differences in arrhythmias, hypotension, syncope, discontinuation rates. I think, in fact, the tolerability between Aficamten and Metoporol is pretty much the same, which is actually pretty impressive considering Aficamten is doing something a little bit more precise than Metoporol is. So I think the overall safety profile is essentially that Aficamten behaves very much the way you'd hope a myosin inhibitor would. It's well tolerated. I think the adverse event profile looks a lot like metoprolol with a modest EF reduction around 4 points, which is predictable, reversible, and almost didn't really cross the abnormal territory. And I think when you zoom out, the whole safety curve is actually remarkable for a clean drug that's dialing back contractile forces in it at a molecular level. And I think that's really important when we start talking about whether this therapy is actually realistic to use outside of just this controlled trial environment. So in terms of like the strengths and limitations of the study, I think it's a clean, well-constructed, randomized control double-blind, double dummy study. And I think the design was tight, the blinding was preserved, the patient population looks exactly like the patient population we'd see in clinic, symptomatic, Holcomb patient with real gradients, real limitations. So from the outset, I think the internal validity is quite strong. Using CPET as the primary endpoint and is another major win in my opinion. Peak oxygen consumption is one of the very few metrics in Holcomb that's brutally honest. And I think you could debate that NEHA class until everyone gets tired, but you can't really debate oxygen consumption. And here the signal is not only statistically solid, I think it's physiologically coherent, as I mentioned. And I think what makes this especially compelling is how neatly every secondary endpoint lined up with the same story. NEHA gets better, KCCQ scores get better, gradients drop, NT-proBNPs fall, the atrium even starts to move in the right direction. And I think when you put all of these things together, you actually see that you're seeing a real biological effect and not just noise. But of course, the trial isn't flawed. It is important to be clear about that. I think the biggest limitation is the washout. Actually, I think stopping all the negative inotropes gives you a beautifully clean pharmacological comparison, but it's not something we usually do in the real world for understandable reasons. So the metoprolol arm here might not fully reflect how beta blockers perform when used the way we normally use them. I think the 24 duration is another practical limitation. I think 6 months is long enough to show physiologic improvement, but nowhere long enough to answer the bigger questions like durability, arrhythmia burden, AF progression, remodeling over years, and whether something eventually needs septal reduction anyway. So, in Holcomb is a lifelong condition, and we still just don't have long-term data yet. I think the sample size is respectable, but still modest for like safety detection, especially for rare EF-related events or arrhythmias. And the study population, while appropriate, I think included a good number of newly diagnosed or treatment naive patients. Those patients often respond more favorably than the long-standing patients who are usually heavily fibrotic Holcomb patients that we sometimes see in our clinics. And I think finally, the Maple-HCM trial doesn't really answer two major questions: how Aficamten compares to septal reduction therapy, which is still the gold standard for the dramatic gradient relief that we see, and how Aficamten performs in combination with beta blockers or calcium channel blockers, which is usually how we treat patients in the real world. So overall, I think the trial was very well executed. I think it was internally consistent across physiology, symptoms, and biomarkers. Its strengths are genuinely impressive. It had a strong design, objective endpoints, and a pattern of improvement that makes biological sense. I think the limitations are understandable and mostly involved in real world applicability. The washout, the short duration, the modest sample size, and the somewhat clean patient population. But I think taken together, the trial essentially tells us that Aficamten is definitely a highly effective, well tolerated, and actually, I think it moves the needle on physiology and Holcomb. I think we just need more longer term data, broader comparative studies to understand exactly where it fits into our long term management landscape, especially relative to septal reduction therapy and combination therapy with beta blockers and the calcium channel blockers. And so to wrap up, like I said, I think it really gives us the clearest head-to-head look we've ever had between a targeted myosin inhibitor and our long-standing first-line therapy. And I think it forces us to acknowledge something we all kind of knew but never really said out loud, that beta blockers and the non-DHP calcium channel blockers are first-line therapy, mainly because they've always been. I think the evidence behind them is decades old, and we really rooted and it's really rooted in tradition more than physiology, and they don't usually improve exercise capacity in a dramatic way. I think Aficamten, meanwhile, goes right to the underlying biophysical problem, excessive actin myosin and cross-bridge cycling, and that actually modulates the hypercontractility that drives the obstruction. But like I said, it isn't a magic drug. I mean, even with Aficamten, a lot of the patients still had abnormal diastolic parameters, gradients in the 30s or low 40s, and knee-high 2 symptoms. It's a strong therapy, but it's not really reversing fibrosis that's pretty much already set in. I think once the myocardium becomes fibrotic, you're essentially asking physiology to undo structural remodeling. And that's something that, the myosin inhibitors can't really fix. So I think that this naturally raises the question in the field heading forward, what if we start using these medications earlier before the fibrosis actually sets in? And I think there's some preclinical data that suggests that early myosin inhibition may actually prevent this phenotype from fully developing, which is pretty much a major conceptual shift. I think in practice, this trial challenges to rethink the automatic reflex we have to immediately put every HOCM patient on a beta blocker. And I think Aficamten may be more clearly more effective, but this therapy still needs to be individualized to the patients we're seeing in clinic. And then lastly, I think looking forward, the trial really sets the stage for where the field needs to go next. I think the trial gives us a strong short-term signal. The gradients fall, the oxygen consumption improves, the diastolic indices move in the right direction, but it also makes it clear we're not only seeing part of the story. I think the 24 weeks duration is enough to show how Aficamten works, but it's not really enough to tell us how durable these benefits are really going to be. I think we still need long-term data to understand whether the gradient reductions persist, whether the EF remains stable, and whether symptom improvement actually translate into slower disease progression over the years rather than months. And then there's also, I think, a real need to understand how Aficamten fits into the therapies we already use. I think the trial tested pure monotherapy, which is methodologically clean but not representative of actual practice. So most real-world patients on beta blockers or verapamil or disopyramide before we even start thinking about adding something new. So I think the next wave of studies needs to answer some practical questions like, can we safely combine Aficamten with existing therapy? Should we taper back background meds? Does a stacked approach improve outcomes? Does the myosin inhibitor do the heavy lifting on its own? And then I think another future direction is the comparative effectiveness. So I think the degree of gradient achieved with Aficamten approaches what some patients experience after septal reduction therapy. But even though septal reduction therapy still remains the standard of durable relief for these patients, especially with fibrosis and advanced remodeling, I think we'll need trials to examine hybrid strategies or head-to-head comparisons so we can determine whether Aficamten as an alternative, a bridge, or adjunct in patients with severe obstruction. And then I think it opens another frontiers in terms of expanding beyond obstructive disease entirely. I think maybe starting to using these drug therapies in patients that haven't really developed an obstruction is something to look at in the future. And I think in the end, this trial moves the field in a forward, meaningful way. I think it shows that we can finally target the fundamental physiology of HOCM directly and not just compensate for it. I think it honestly marks the beginning of a new therapy chapter in managing HOCM, but the challenge I think now will be, translating the short-term physiologic wins into long-term clinical applications, honestly. But yeah, so that is the end. I think, like I said, I think hopefully this gave you a clearer sense of what the trial shows and what it doesn't, and how it actually may change the way we think in treating our HOCM patients.
Thanks, Q. That was a really good summary of the article, and we'll open it up to any questions or comments. We have some of our HCM specialists on the call, so it would be great to hear from them.
Yeah, I'll make a comment. Good morning, everyone. Great job, Q. This was a fantastic paper to pick. I think this was a very important paper in the world of HCM. Lots of hard work went into this study. And I want to zoom out a little bit and, draw everybody's attention to the big HCM landscape. What's happening in the field? So when you look at the treatment of HCM, when you look at the big paradigm, we've been using the same medications in the field for almost 50 years, same beta blockers, calcium channel blockers. We had some observational data which was scattered here and there, that suggested maybe they might work with some of the symptoms of the patients, but we really never studied these medications in an RCT. And then in 22 came in Explorer-HCM, which did look into Mavacamten as a second-line agent in addition to background medical therapy. And it was very effective because these are disease-modifying therapies. So Mavacamten worked, and we have been using Mavacamten in the field of HCM for the past 3.5 years, and it does a great job. And I think the main paradigm that's shifting right now is with Maple. So Maple actually has shaken the ground and looked into, and this is the first time this is actually happening in the field of HCM, looked into a new therapy as a comparison to standard background medical therapy. And Aficamten is more efficacious than Metoporol in the field of HCM. So I think what is going to happen in the field is now that Aficamten is probably get an FDA approval in the next couple of months and probably is going to become the first-line therapy in obstructive patients with HCM. So that's the big picture. And can you go ahead and pull up that slide that looked into the gradients?
Yeah.
I think it was slide number 10 or so.
Let me go back and see.
So I want to highlight that this slide as well. So I think to me, this was probably the most important data from Maple. If you look at the resting and the Valsalva LVOT gradients with metoprolol and Aficamten, you'll see a flat line with metoprolol and it drops with Aficamten, right? So this is not what we were expecting when we were designing this trial. In clinical practice, many physicians have been using beta blockers for ages. And anecdotally, I think, some patients do benefit, some patients do not. Some patients we have seen improvement in LVOT gradients, especially with exercise. Some patients do feel better in terms of their symptoms, but this was the first RCT that looked into metoprolol hemodynamic outcomes in obstructive HCM. And it was impressive that there was no overall benefit. And the metoprolol dosing was not underdosed. I mean, patients were on pretty hefty doses of beta blockers, probably more than what we use in clinical practice. So again, I think this was very important data, which is going to change the HCM paradigm in the long run. So in the next couple of months, again, we are probably going to get Aficamten in the field as well. And I do anticipate that the guidelines is going to have an update to include Aficamten as a first-line therapy.
Yeah, real quick, we're running late, I know, but the main difference we think, or the main difference for Aficamten, compared to the original Mavacamten is fewer drug-drug interactions, which will be nice, but they both appear to be extremely effective, means of reducing symptoms and gradients. And we do have good now 3-year safety data with Mavacamten. So our, sort of short, long-term safety data appears to be quite good. Thanks. Good job, Q.
Thank you.
And I think we have many fellows in the audience. I just want to make one more comment. So I think it's incredibly important for all of us to delineate the hemodynamics of each HCM patient. So remember, these are approved for only patients with obstructive HCM. So we have to define obstruction really well. Most patients don't have obstruction at rest, but you can provoke obstruction with a good Valsalva maneuver and sometimes with exercise as well. So it's important for everyone, and all of you are going to go into practice to make sure that you do not rule out these medications as an option before you actually looked into a good Valsalva maneuver plus an exercise test as well to see if your patients have LVOT gradients. And then I think the second point is, and I get this question a lot, then what are we doing in current clinical practice with the background medical therapy? Are we stopping beta blockers and CCBs? Can we reduce them with Mavacamten? So we looked into Mavacamten as monotherapy in the field as well, and it does seem to be very effective as a monotherapy. And when we looked into the real world data in patients who got on Mava and stopped their background medical therapy or reduced their background medical therapy, they did fine. The efficacy did not change. It was safe to stop him. And, these are medications, they do cause a lot of side effects, right? They cause lots of fatigue and ED and hair loss and weight gain. They're not free of side effects. So, and it doesn't really make any sense to combine a weak negative inotrope with a strong negative inotrope when you need only one. So this is my practice, I guess, unless you have a strong concomitant indication for a beta blocker, I feel safe to stop them or to reduce them in dosage.
Just in the interest of time, because we still have one more study to present, I'm going to have Sophie start with hers. But again, thanks, Q, and thanks for all of our commenters on the first study.
Yeah, thank you, Dr. Coley, and thank you, Q. That was really awesome. Can everyone see my screen? Okay. Well, I'll go ahead and get started in the interest of time. So I'm doing my senior journal club today as well. And it is about beta blockers after myocardial infarction without reduced ejection fraction, known as the reboot trial. So this came out in August. I think it's a really interesting trial, so I wanted to talk about it today. So just a few learning objectives. First thing, to review the existing evidence for beta blocker therapy in patients with acute MI without reduced EF, to discuss this trial and the conclusions, and then, of course, to consider the clinical implications and potential practice changes that we might make based on this trial. Okay, so just some brief background. This is pretty straightforward. We all do this, fairly often, but you see something like this, something like a STEMI on an EKG, what do? What's the next step? Of course, you call interventional after you freak out. You go to the cath lab. You do what you need to do. Ideally, reperfusion, some kind of stent. Again, ideally, they do well in the cath lab. You watch them for a little bit and you start all the usual medicines. We have DAPT, we have statins, we have ACE inhibitors, and often we have like beta blockers that we'll use. So it's pretty algorithmic. We're all very used to doing this. Seems pretty straightforward. And, ideally the patients do well. And why we do this. So this is the general thinking, and it makes sense when you think about it of why specifically we use beta blockers after MI. So beta blockers, as we know, suppress the beta 1 adrenergic activation that decreases the myocardial contractility, that decreases the stroke volume, it decreases the heart rate, you decrease cardiac output, decrease blood pressure, decrease afterload, and then you decrease the oxygen demand of the heart. Also, you will increase diastolic period, increase coronary perfusion, increase the myocardial oxygen supply. All this seems really clear that it would help improve myocardial ischemia. So, I think that it makes sense why we think beta blockers are a great drug to use after MI. So a little more background. Beta blockers have long been a cornerstone of treatment after MI because of this thinking. And actually, the early trials really supported their use. So the BOT trial, which was beta blocker heart attack trial, was in 1982. It was the first large randomized trial to demonstrate a significant reduction in mortality when treating patients with recent MI with a beta blocker. And then a few years later, the ISIS-1 trial showed IV atenolol followed by oral administration over 7 days reduced vascular and all-cause mortality in patients presenting with suspected MI over the course of 7 days and 1 year, so short and long term. And then there was another big review of randomized trials in 1985 that looked over 50,000 patients, over 65 trials, and it did show a 23% lower risk of death among patients who received beta blockers than among those in the control group at 2 years. So this is all pretty convincing data if you just look at this at face value. However, the problem is that these early trials had limitations, and most notably, they were conducted in a time when the standard for post-MI care was completely different than what it is today. You'll notice I said those trials, those were in the 80s, some of them were even in the 60s and 70s. At that time, reperfusion, whether that be like thrombolytics or PCI, had not become standard of care. Dual antiplatelet therapy wasn't in use. Statins were not part of routine care either. So it's essentially comparing apples and oranges. How we treated MI back then is not at all how we treat it now. So it's hard to take these studies from the 80s at face value. We kind of need to re-examine the role of beta blockers, particularly in patients with uncomplicated MI and a preserved or mildly reduced ejection fraction, meaning greater than 40%. Okay. So there's a little bit more recent trials that kind of support this reexamination. Things like the Commit trial in 2005 had over 45,000 patients, showed that the use of early beta blocker therapy in acute MI reduces the risk of reinfarction and VFib, but actually increases the risk of cardiogenic shock, especially during the first few days after admission. There was some treatment effect heterogeneity in that, meaning that in the low risk stable patients, metoprolol helped, but in higher risk unstable patients, it actually worsened things. And then the biggest one, the Reduced AMI trial in 2024, that did show no evidence of benefit from beta blocker therapy. Again, there were some limitations to this trial, but this is really the first one that made us kind of rethink how we use beta blockers after MI. Of note, it did exclude patients with a mildly reduced EF. So like 40 to 50, those patients were not included. And then, of course, in patients with a reduced EF, less than 40%, the benefit of beta blockers has been well established in contemporary data. So there's really no question that reduced EF, like any other patient with a reduced EF, beta blocker is helpful. And the Capricorn trial was one of the biggest trials to confirm that. So despite these trials kind of showing mixed data and these more recent trials kind of making us think that maybe it's not necessarily, beta blockers are not necessarily providing benefit, the 2025 guidelines of the ACC, the AHA, American College of Emergency Physicians, National Association of Emergency Medical Services, as well as the European Society for Cardiology, all of them still endorse the use of beta blockers in these patients. And it's actually a 1A recommendation. So even though the data is kind of coming out a little iffy, it is still a 1A recommendation. So we are still all doing it. So this study, what are we actually looking at here? So the participants kind of laid it out there by saying we conducted the treatment with beta blockers after MI without reduced ejection fraction trial to determine whether oral beta blocker therapy initiated at hospital discharge in patients with acute MI and a preserved or mildly reduced LVEF would lead to a lower risk of a composite of death from any cause, reinfarction, or hospitalization for heart failure than no beta blocker therapy. So getting right into the methods, conducted 109 centers across Spain and Italy according to a probe design. The trial group assignments were not concealed, but clinical outcomes were centrally adjudicated by a committee whose members were unaware of the trial group assignments. Centrally adjudicated meaning they were evaluated by the central independent group of experts rather than by the local investigators to try to help with the fact that it was not blinded. Okay, getting right into the patients. Which patients do we pick for this? The inclusion criteria is pretty straightforward. Patients with type 1 or 2 MI with or without ST segment elevation who had received invasive care. Interestingly, invasive care is defined as having a coronary angiography, regardless of the final therapeutic strategy. So even if you did not necessarily get a stent, if there was a left heart cath, that's invasive care. And of course, had the EF greater than or equal to 40% before discharge. Exclusion, any history of heart failure, any severe valvular heart disease, any contraindication to beta blocker therapy, of course, and then any indication for beta blocker therapy that was unrelated to the MI as determined by the treating physician. So nothing too crazy here. This all makes sense. And now the procedure. Basically, patients were randomly assigned in a 1-to-1 ratio to receive either the beta blocker therapy or no beta blocker. In the treatment group, the type and dose of beta blocker were determined by the managing physician. And then the randomization was performed at the time of hospital discharge or within 14 days. And then there was follow-up, and this data was obtained through telephone interviews, review of medical records, and national registries. And we had follow-up at 3 months, 15 months, 36 months, and 48 months. All right, now on to the outcomes. As we already mentioned, the primary outcome is a composite of death from any cause, reinfarction, or hospitalization for heart failure. Secondary outcomes, individual components of the primary outcome, death from cardiac causes, sustained VT, VF, and resuscitated cardiac arrest. And then tertiary outcomes were unplanned revascularization and a composite of death from cardiac causes, stroke, or MI. And then, of course, some safety outcomes, hospitalization for advanced AV block, meeting Mobitz type 2 second degree or third degree, and hospitalization for stroke. The statistical analysis, I won't get too much into that, but it was performed according to the intention to treat principle with the use of proportional hazards models. All right, so the basic patient population, we started out, and this was between October 2018 through April 2024, a total of 8,505 patients underwent randomization. So we ended up putting 4243 assigned to beta blocker group and 4262 to the no beta blocker group. However, after we excluded patients who they didn't get consent, they didn't necessarily meet eligibility, there was some issue with their randomization. After that, we ended up getting to a final number of, I don't think I changed it, but after that, it ended up going down to 4207 in the beta blocker group and 4231 in the non-beta blocker group. And so this is a little bit about the patients. Interestingly, the mean participant age was 61. That's pretty consistent with kind of what we see with our MI patients. 19.4% were women. Of course, we would love to have more women in this study, but this also is not too different than what we see in clinical practice. 52% had hypertension, 20% had diabetes, 50% had dyslipidemia. All of this is pretty consistent with what we see, so nothing too shocking here. Of note, almost 10% had a previous MI, which I thought was interesting. Something else that I think is interesting is STEMI versus NSTEMI. It's essentially 50-50. And then who actually got PCI, it was 93.5%. So nearly everyone actually did have a true invasive management. All right, now on to what beta blockers we actually used. So as I mentioned earlier, this was at the discretion of the treating physician. And interestingly, you can see the widest amount used bisoprolol. That was actually 85.9% of the patients were on bisoprolol, 7.5 on metoprolol, 3.1 on carvedilol, and 2.8 on nebivolol. That might be surprising to us. Of course, we kind of love metoprolol, carvedilol, but in Europe, using the bisoprolol is actually pretty consistent with what they do. So this was not surprising in this trial done in Spain and Italy. Okay. Again, in the interest of time, I want to get straight into the results because they are really interesting. So first thing first, the primary outcome, death from any cause, reinfarction, or hospitalization for heart failure. The primary outcome occurred in 316 patients in the beta blocker group and 307 patients in the no beta blocker group. So not statistically significant. And you can see on that graph that, those lines are basically on top of each other. And then if you look at B, C, and D, death from any cause, reinfarction, or hospitalization for heart failure, again, those lines are basically on top of each other. They're pretty much exactly the same. Just to put numbers to it, death from any cause occurred in 161 patients in the beta blocker group and 153 in the no beta blocker group. Reinfarction in 143 in the beta blocker group and 143 in the no beta blocker group, so exactly the same. And then hospitalization for heart failure occurred in 39 patients in the beta blocker group and in 44 patients in the non-beta blocker group. So none of this had any statistically significant difference. And I think visually you can see that from what the graphs look like. As far as safety outcomes, I'll just briefly mention them, but essentially they showed no difference either. Hospitalization for symptomatic advanced AV block occurred in 7 patients in the beta blocker group and in 6 patients in the no beta blocker group. And then hospitalization for stroke occurred in 37 patients in the beta blocker group and 25 in the non-beta blocker group. So if anything, there really is no difference. If anything, maybe in some of these, a slight non-significant better outcomes in the no beta blocker group. But really, there's no statistical significance, no difference between the two. And this is just, again, putting numbers to all of the secondary and tertiary outcomes. Just if you want to see the full data, comparing them, you can see that really there's no significant difference. Sustained VT, 3 versus 2, VFib, 3 versus 5. Death from cardiac causes, 235 versus 216. So really every primary, secondary, tertiary outcome, there is no big difference. So the conclusion, unsurprisingly, is that among patients who had been discharged after invasive care for an MI and who had had left ventricular ejection fraction of more than 40%, treatment with beta blockers showed no evidence of an effect on the incidence of death from any cause, reinfarction, or hospitalization for heart failure during a median follow-up of 3.7 years. And then additionally, there was no apparent between group difference in any of the secondary or tertiary efficacy outcomes, like I just showed on the previous chart. So getting into the most interesting part, which I think is the discussion, like what do we take from this trial? Interestingly, these results are in line with those of the Reduced AMI trial from 2024. So, these more recent trials are showing more consistent data that beta blockers are not providing benefit in these specific patients. And then some previous studies had kind of started to suggest that the clinical benefit of beta blockers might be limited to the first year after MI. And maybe after that first year, there isn't any benefit. But in this trial, the event rates for the primary outcomes were consistent throughout the follow-up period, including the first year after the index event when the risk of adverse outcomes, like specifically reinfarction, are typically the highest. So, something else that I think a lot of us are probably thinking when we see this trial is, okay, fine, EF greater than 50%, sure, you can say there's no benefit, but what about that gray area? What about mildly reduced ejection fraction, like 40 to 50? So in the pre-specified subgroup analysis, there was no apparent difference on the basis of the subgroups according to EF, but in those patients with a mildly reduced EF, fewer events did occur in the beta blocker group than in the no beta blocker group. However, the number of patients in this subgroup was less than 1,000, and it just really limited the interpretability so that there was not significance. However, if we kind of use a pooled analysis and kind of compare this and pool it with some other studies, it is certainly possible that with mildly reduced ejection fraction, similar to just reduced ejection fraction, the beta blockers will provide some benefit. But in this study, there just was not enough data. There weren't enough numbers of the patients in that specific subgroup. All right, limitations. Of course, this was an open label trial. That's always a limitation. But as I mentioned, there was blinded central adjudication. So that mitigates that limitation a little bit. They did the best they could to kind of help not have any bias there. The enrollment period was a little longer than expected. Even so, all patients were treated according to current clinical best practice. Planned sample size was reached, but the overall event rate was actually a little lower than anticipated, 623 versus 728. The protocol did not mandate beta blocker dose adjustments. And actually in the Reduced AMI trial, they kind of had a beta blocker up titration protocol, and here it was left to clinical discretion. But that's how we're going to do it in practice is, it's at the clinician's discretion. And interestingly, the doses of the final beta blockers were not significantly different in this trial versus Reduced AMI. So the clinicians were kind of pretty much on target with what we would do. So it doesn't seem that made a big difference. And then heart rate monitoring was not required during follow-up. Okay. So now I think the most interesting question, and again, I kind of sped through some of this, but I really wanted to leave room for questions or discussion because going forward, do we think this study will provide enough evidence to change how we as cardiologists prescribe beta blocker after MI? And, I'd love to hear from anyone who has any opinions of will this change your own clinical practice? Is anyone actually going to stop and give a second thought in a patient with like EF 55%, uncomplicated MI? Are we going to send them home without a beta blocker? And then another interesting question, I think, is how will this affect practice guidelines? Because like I mentioned before, beta blockers after MI in patients with preserved ejection fraction is still a 1A recommendation, meaning like we should be doing this. But with this new data, do we think that those guidelines are going to change? Are the guidelines going to keep up with the evidence? That's not always the case, but I'd be interesting to see what like the AHA, the ACC, what everyone makes of this study. Okay, thank you. And yeah, there's Luke and Oliver just saying thank you for listening. But if anyone has any thoughts, I would love to hear from y'all. Any thoughts, any questions, any input?
Sophie, this is Mike Burke. Can you hear me?
I can.
Great. That was great. That was a really nice review. Instead of trying to predict what will happen with the next guidelines, and as a guideline writer, I would contest that we don't always stick to the evidence. Oftentimes there's more nuance in there. And I think that that's the case here. So what do you think is going on here, right? Do you think that the old trials were wrong? Or do you think that something has changed about caring for these patients and treating these patients that has rendered the benefit of beta blockers to be less apparent or non-apparent, I guess you could say? And if so, what?
Yeah, absolutely. No, I don't think the old trials are wrong at all. I think that exactly like you're kind of hinting at, the way we treat MI now has changed since then. So like, back in the 80s, whenever these trials were done, the lack of reperfusion therapy in MI led to serious heart muscle injury. So, when you have heart muscle injury, the blockade of sympathetic overflow, it makes sense that that would reduce MI complications when, the mechanism is serious heart muscle injury. Now, when we are having rapid restoration of blood flow with like stents, interventions, things like that, the mechanism is not exactly the same. So I think that's why the beta blockers, specifically stopping that sympathetic overflow, is not necessarily providing as much of a benefit in these patients who have had early revascularization. And I think that might be the case with this study because, the patients who have a preserved EF, who had intervention, and those are two inclusion criteria for this study, these patients are the ones who are not necessarily having that heart muscle injury. So I think that's it's a different mechanism. It's a different way of treatment. We have different standards now, and I think that's what's going on.
Okay. Yeah, I would actually fast forward the timeline and indicate that I think a big thing is the change in stent technology. Because if we fast forward the timeline, the Commit Metoporol trial came out when I was in training, and it was an impressive trial because already there was starting to be some signal at that time and murmuring that baby beta blockers wouldn't be all that effective in the modern era, but they still clearly were. But that was with, I'd have to look back at Commit to see because it's been 20 years, but I think there were quite a few bare metal stents in there. And that was also during the era of the first generation, like Cypher and Taxus stents. And what we have nowadays is clearly superior to that as well. So I think early revascularization and the fact that the stents we're using now to keep the vessels open are better, all contribute to this. So this is just it's medicine progressing. What would be interesting too, though, is to see an ACE inhibitor trial because we really haven't had much on that front, not big ones anyway, since the HOPE trial, and a lot has changed since then as well.
Absolutely. Yeah. I think that looking at like ACE is a natural next step. So I think that would be really interesting. Thank you, Dr. Burt.
Right. I hate to end the discussion because I'm sure there's a lot of good commentary here. I appreciate everyone staying a little late today. Thank you all for being here and happy Thanksgiving. Great job, Sophie.
Thank you.
The preceding program is copyrighted by Emory University.